We're nearly back on track. We're coming down the final stretch. This is a recorded session. Dr. Ron Gross is going to enlighten us on his thoughts about optimal peer review as it relates to chest wall surgery.
Good afternoon, everyone, and welcome to Park City, Utah. I'd been asked to talk about optimal clinical case peer review. And although, unfortunately, I can't join you all here, I do hope that this talk might generate a bit of thought and discussion after the fact. I do have a disclosure. I have received honoraria in the past from J&J Synthes as both a course director and a lecturer. Okay, I'll be honest. When Sarah asked me to give this talk, I thought, really? How lame. But when I thought about it, I thought it's probably not a bad idea. We are such a highly specialized bunch of providers who are, as Gene Moore said, making history. Perhaps we need to look at the way we are doing things. Peers. Well, what is peer review and what is a peer? A peer is one that is of equal standing with another, or one belonging to the same societal group. Well, clearly we, as members of the Chest Wall Injury Society and those who do a lot of this surgical care of chest wall injuries, are a select group and have few peers in the world of general surgery. Keep that in mind as we move forward, and then look at the term peer review. Well, peer review, we all know, it's the evaluation of scientific, academic, or professional work by others working in the same field. Again, we don't have many peers. So let's think about this for a little bit over the course of this discussion. Can chest wall injury cases being treated surgically with SSRF be appropriately peer reviewed in most general surgical department morbidity and mortality peer review or PI conferences? That is the question that we need to review and talk about. Let me talk about Dr. Ernest Codman for just a minute. Dr. Codman has been labeled the founder of PI. And if you take a look at the plaque that is mounted in the MGH, you can see that he felt it would take over 100 years before his ideas were accepted. Dr. Codman graduated from the Harvard Medical School in 1895, and he joined the staff of the MGH, where he practiced until 1914. When he left, after they prohibited him from using the M&M discussions for evaluating surgeon competence, Codman went on to form his own hospital, which he called the End Result Hospital, and it was patterned in principle after the 4 bullets that you see here. Dr. Codman was one of the leaders in the formation of the American College of Surgeons, which was established in 1913. One of the programs that was instituted at the very beginning of the ACS life was the Hospitalization Standardization Program, which was the inspiration for the formation of JACO, or the now known as the Joint Commission, in 1951. Codman codified the concepts of morbidity and mortality conferences to examine the cases that were done and find out what the good and the bad were of each, and when there were problems, how do we fix them? He publicly supported the auditing of all surgical outcomes for the purpose of quality improvement, and wanted to follow surgeons as they practiced so that their results could be analyzed. And that was, as I said earlier, the reason why he left the MGH, because they wouldn't allow him to do that. For many years after Codman's initial work, there remained an unwillingness in the physician community to review and critique the work of their colleagues, and quite frankly, to have their work critiqued as well. Well, there are many reasons for that. The early peer review process was initially overseen by state licensing boards, and so physicians were unwilling to review and critique the work of their colleagues and their work because it was being overseen by these licensing boards, and so there was a lack of physician participation in the peer review process. More importantly, physicians were unwilling to enforce any disciplinary actions that arose from issues identified during the peer review process, again, because all of this was being overseen by the state licensing board. More worrisome than anything else, however, was the fact that with the state-by-state overview of the peer review process, physicians with problems could pick up and leave. They could just move and have no record of any problems. And lastly, the peer review process was discoverable. In 1986, a landmark act called the Health Care Quality Improvement Act was signed by President Reagan, and this act had two major goals. Number one, to provide legal protection to hospitals and physicians for activities conducted under the auspices of peer review. And number two, to develop the National Physician or Practitioner Data Bank. The goal of this data bank is to be a repository for all adverse actions involving physicians. And specifically, access to this was restricted to third parties involved in physician credentialing and regulation. Well, that's all. Although the peer review process does have specific elements that could cause problems, probably for our discussion, the most significant problem would be the lack of adequate resources and specifically the unavailability of external reviewers. Obviously, work group bias could be a problem if one group feels that we're taking away cases from another, but I think that the first is probably the major issue. A really good review by Orlander and their crew in Academic Medicine 20 years ago took a look at the Morbidity and Mortality Conference, and their comment, and I'm going to read this, appears to have sprung from the efforts of physicians to improve practice through the examination of medical errors and bad outcomes. Learning from one's errors is important, but confronting them is difficult, and is particularly delicate when done in an open conference. If the effort is successful, it can serve as a model. However, if unsuccessful, it can instead convey the lesson that attempting to learn from error is at best unproductive and at worst unpleasant. They went on to say that M&M is a double-edged sword, and they basically said you need to pay attention to the way you are conducting it. A couple of years ago, Churchill and colleagues took a look at the evolution of the Morbidity and Mortality Conference, and they realized that there was a new focus on patient safety and quality improvement. And this proposal was a shift from analysis of incidents that may or may not be preventable to those that have system-wide implications of failure, even in the face of no actual harm to the patient. This was a major shift, and they felt that it had come about over the last decade or so. They felt that there were three major themes associated with this change in focus: careful case selection, the format of the discussion, and the resulting QI initiatives and their implementation. I would submit to you that in addition to those three, another major change was a change in taxonomy of peer review and the PIPS process. The topic course used the word judgment and related it to both issues and mortality. When looking at issues, issue judgment determinations looked at process and system-related issues where the event or the complication was not related to the provider or the disease, but rather to systems. They looked at outcome and disease-related issues where the event or the complication that is an expected sequela of a disease, illness, or injury has to be examined. And lastly, provider-related issues where the event or the complication resulted from the care leading to delays or errors. When looking at mortality, the mortality judgment categories were changed, and the whole goal of this taxonomy was to eliminate blame. The mortality judgment categories included non-preventable, potentially preventable, and preventable. And lastly, looking at preventable, it is an event or a complication that is the expected or unexpected result of a procedure, disease, illness, or injury that could have been prevented or ameliorated, whereas non-preventable means everything was done and the event occurred anyway. So This is the CWIS Summit. This is the Chest Wall Injury Summit. Why should we care about any of this? Well, I've been asked to talk about. So let's take a look at the goals of peer review. What are we after? What do we want to see? Well, obviously, peer review is to make sure that we ensure and maintain the highest quality standards in the work we do every day. It's to improve performance where there can be improvement. It's to provide credibility in the work that we're doing. And for scientific research, it's to take a look at everything that's submitted for publication and make sure that it is ultimately the best possible submission that is evidence-based. Richmond and colleagues felt that the current iteration of the peer review process was essential, but there was room for improvement. And they felt that a fundamental change in the way we do the peer review, i.e. the culture, may be the best remedy. So now we've taken a look at the history of peer review. We've looked at some theories about the process. We're pretty specific and very focused subspecialty. How do we apply all of this thought to what we are doing in reviewing our cases? I think it is safe to make some basic assumptions when talking about presenting chest wall injury cases at a general surgical M&M. Until recently, chest wall injuries have been managed exclusively by thoracic surgeons, and 80% of those cases were managed non-operatively. Until recently, rib fixation has not had a really good historical perspective, and until recently, rib fixation has not been universally accepted or practiced, especially by general surgeons. Given that, then the question must be, how can we successfully review our strengths and weaknesses, our successes and failures at a general surgical M&M if most of our colleagues do not have the clinical knowledge or the technical expertise to make judgments on chest wall injury care and outcomes? Let's go back to that slide talking about the elements of a flawed peer review process and look at the first bullet. Lack of adequate resources, i.e., the unavailability of external reviewers. Well, I think that really applies to us because, as I've said, we are a very specialized society and we do subspecialty work. So what are the steps to achieve optimal peer review and M&M process for chest wall injury cases? Number one, the Chest Wall Injury Society publications provide current peer-reviewed references for use in the discussions to educate, if you will, the masses, those general surgeons who have not seen or are unfamiliar with what we do. There are many ways that we can look for assistance when we need to review our work. We have Slack, we have CWIS mentors and colleagues, all of whom can provide one-on-one case reviews and discussions, both preoperatively and then for the postoperative discussions to look at system issues and problems, our complications, and obviously our successes. We need to work hard as we move forward to establish credentialing requirements specific for general surgeons managing and operating on chest wall injuries. We need to look at training requirements, supervision policies, and whether or not we need to have some specific minimum caseloads, much the same as we did when laparoscopic cholecystectomies or appendectomies were first initiated in the general surgical armamentarium. We need to help develop OPPE and FPPE specific to the subspecialty standards that we have accepted. We need to collaborate with our department chairs to adopt and widely share the established standards and requirements that we as a group have come up with. It needs to be evidence-based, and the techniques and technologies need to be shown to work well. This will level the playing field when we present our results at a general surgical M&M where most of our colleagues do not do what we do. We need to provide adequate resources, which is something that we've seen as a flaw. We need to revise hospital policies regarding the use of outside reviewers at our M&M and PIPS conferences if necessary. We need to establish qualifications for those who are going to provide the outside reviews. We need to ensure PI protection for those outside reviewers, and we need to include those outside reviewers in the presentation, discussion, and judgment of the chest wall injury cases at our M&M and peer review conferences. So, how do we provide the optimal clinical case peer review? I would suggest that it's as easy as applying Codman's end result idea to chest wall injury discussions in general surgery, morbidity and mortality, and peer review meetings. Let's discuss our results openly and apply the topic taxonomy, and where needed, use qualified outside reviewers. Analyze our results and let's find out where our problems are and where we are doing well. Do we have a problem with case selection or surgeon performance? Do we lack the availability of qualified assistance? And have we had a problem with the equipment that we're using? Let's look for the opportunities for improvement and discuss them openly. If necessary, let's form something like TQIP for surgical stabilization of rib fractures. And let's welcome publicity when it comes to constructive commentary, not only for our successes, but for our errors or for our failures. In closing, our goal is simple: an evidence-based optimal peer review and performance improvement of all chest wall injury cases in all general surgical morbidity and mortality conferences and peer review conferences. Thank you for the opportunity to present to you today. Please feel free to contact me if you have any questions.